Up next, we have Dr. Duckworth, who is an assistant professor with the Cancer Patient Support and Psychosocial Oncology programs with Wake Forest. Her clinical and research interests include adjustment to chronic health conditions, pregnancy and cancer care, young adult survivorship, sleep quality, end of life care, and existentialism. And she's going to be sharing an awesome presentation today. So take the floor.
Great. Thank you so much for having me this afternoon. I'm going to be talking with you guys a little bit about caregiver well-being today. The title of my presentation is Providing Care Throughout Intensive Interventions, a close look at caregiver well-being. So some of the objectives that I've laid out for us today include underscoring some of the many strengths and challenges that informal caregivers confront when loved ones undergo intensive interventions, reviewing some data that we've collected here at Wake Forest on the well-being of caregivers to our surgical oncology patients, and proposing some data-informed research and clinical practices pertaining to caregivers. So before we get moving, I really wanted to make sure that we have a shared lexicon, a shared understanding as to how I'm defining caregiver, and I'm pulling this definition directly from the NCI. And we're going to have the basic definition of a person who gives care to people who need help taking care of themselves. And most of us differentiate formal caregiving from informal caregiving. And today I'm really going to be focusing my talk on informal caregivers, the folks who are day in and day out staying at the bedside or at home with our patients. So when we're talking about informal caregiving, we're thinking about certain types of care provision. We're thinking about focusing on activities of daily living, instrumental activities, emotional support, and healthcare communication. The data suggests that most informal caregivers provide at least 33 or more hours of weekly caregiving assistance. This in turn places them at high risk for mental health concerns, sleep quality impairment, and also just basic reduced self-care. As such, we can glean that caregiving is both physically and psychologically demanding, and yet it also has its own unique rewards as well. So a range of variables impact our caregiver well-being. And when we're thinking about our own surgical oncology population, we're thinking about all kinds of issues that our caregivers confront here. We're thinking about the amount of time that is needed to provide care, the complexity of presenting concerns of the respective patients, the setting of the care provision, whether or not it's at the home or at bedside here in the hospital, their own well-being and simultaneous role demands, the resources they have available to them, and also the broader context. So within contemporary times, perhaps the strain that they're feeling relative to the pandemic, social disconnection, or any type of economic uncertainty that they're facing. So all of these things can combine and coalesce to contribute to what we describe as caregiver burden, which is defined as the stress or strain felt by the person who cares for the patient. And essentially this burden occurs when the demands of caregiving are greater than, exceed the resources that our caregivers have available to them, whether or not those are internal or external resources. The literature is also supporting the fact that different caregivers might have differential experiences, including the role of gender in the caregiving experience, as well as age. So perhaps being on the younger end of the spectrum or the older end of the spectrum might in turn impact how our caregivers adapt and cope. We know across the board that caregivers underutilize supportive services, and the services that we have to provide them oftentimes are insufficient. And so this has prompted the question within our group here at Wake as to ask a little bit more about why. Why is this the case? Why do we tend to offer more patient-oriented care to the exclusion of our caregivers sometimes? And why do our caregivers tend to tell us that they experience what they oftentimes describe as a disenfranchised sense of grief or loss, in the sense that their suffering is not necessarily as public or as readily attended to as that of our patients? So all of these collective experiences, these clinical and anecdotal conversations have led us to think about and really pinpoint the challenges that our caregivers here for our HIPEC patients are endorsing. So we want to really be mindful of the scene, of the context, and understand that our patients here undergoing CRS+HIPEC are oftentimes experiencing heavy symptom burdens. We have ample quality of life data that's been published in the literature base that suggests that for the most part, our patients experience some declines in quality of life postoperatively with a return to their baseline quality of life status for the majority around 6 months. And so we feel like we have a pretty good sense as to the general arc for quality of life movement within our patient population. And so we started asking questions about how our caregivers' experience of quality of life and depression might in turn map onto these trajectories. We know a lot of our patients and caregivers are experiencing extra stress related to travel, any complications that their patient counterparts might be experiencing in the hospital. And then of course, the pandemic again has really impacted things like visitor restrictions, economic distress, and just a feeling of pervasive social disconnection for a lot of our caregivers. So all of these reasons make it quite challenging, methodologically speaking, to assess the well-being of caregivers. And yet we recognize the importance, the clinical importance of doing so. And so we have really tried to find a way to put them on the map here. So the aim for some of our newer interventions is to really include caregivers from a research and a clinical perspective. We want to put them on the map relative to this patient population and explore both their self-reported experiences and also some of the procedural aspects of how we can gather data from them and also in turn use that data to create data-informed interventions. So our aim here today was to really try to figure out how to share some exciting caregiver research findings that we have with you, in which we really work to assess and compare the quality of life of both our patients and our caregivers, looking at depressive symptom burdens as well as quality of life trajectories over time. And then look in turn at some of the factors that are associated with quality of life decrements, poorer quality of life within the caregiving population. So for the sake of brevity, I just wanted to highlight some of the instruments that we use within this study looking at caregiver well-being. We use some instrumentation pertaining to quality of life, depression, social support. What's really important here too is to look at the time points at which we administered the instruments. We had 4 longitudinal time points looking at pre-op, post-op, and then 6 and 12 months post-op respectively. In this respective study, we had 73 dyads who consented. 58 pairs returned at least 1 questionnaire, and I'll break that down for you here. But we were really excited about the enthusiasm of both our patients and our caregivers, dyadically speaking, to engage and to share a little bit more about their experiences with us here. So the demographics for this study included patients who had surgical oncology procedures between February of 2016, November of 2017. Average age of our participants was 56, 60% being female. And you can see the primary site of their respective patient counterparts. The leading diagnostic category was appendiceal, followed by colorectal and mesothelioma. And the median length of hospital stay was 8 days for our patients. You see here the dyadic data with the respective longitudinal time points at which we assessed our caregivers. And so we had 44, 38, 34, and subsequently 17 caregivers returning data at these different time points to really inform us about what they were experiencing along this caregiving arc. So our findings, which are really, really fascinating to us here, our caregivers across all time points endorsed higher levels of depressive symptoms. So let me say that one more time because it's really interesting to wrap your mind around, I think. We think about patients as struggling physically and emotionally, but our caregivers here in this study are telling us that they were endorsing higher levels of depressive symptomatology. Take time 1, for example, whereas 16% of patients exhibited depressive symptoms that were significant enough to warrant professional clinical attention, we had 39% of our caregivers endorsing that level of depressive symptomatology. Looking at that arc and how it might change over time, depressive symptoms were highest for our caregivers pre-surgical intervention. They were elevated post, they dropped at 6 months, and then elevated again at 12 months. I'm a visual person, so I promise a graph here is coming to follow this. But just to think about that arc, we're thinking about not only percentages, but also movement over time. We moved also into the realm of quality of life. So quality of life, similarly to depressive symptomatology, was worse at baseline for our caregivers and improved over time. Looking at both quality of life and depressive symptomatology, we started to highlight this trend that pre-intervention is a really tough time for our caregivers. They're endorsing that they're struggling a lot emotionally, both from a depressive standpoint and a quality of life decrement standpoint. And so we also started paying attention to the different trajectories that we were seeing between patients and caregivers. So here are the promise graphs. Okay, in this circumstance, a high depression score is undesirable. So we see our caregivers, which are the straight line, consistently higher than our patients, who are delineated here by the dotted line. So again, undesirable to have a higher score with depressive symptomatology, consistently tracking at a higher threshold than our patients. So not only can you see the percentages here, but you can also see that arc, that trajectory over time. And we can start to think for subsequent interventions where it might be ideal to start intervening there with our caregiver population. Okay, so let's take a look, moving from depression to quality of life. So quality of life is a little bit different. Higher scores are desirable for quality of life. So we see here with our patients are the solid line, our caregivers are the dotted line. Our caregivers here are endorsing comparatively lower quality of life scores than our patients at pre-treatment. Okay, so let's look real quickly back here. More depression, worse quality of life at time 1. Okay, so then you can move across their arc with our patients and caregivers. Our caregivers have slightly improved quality of life at time 2 and time 3, and then subsequent slight decline there. But again, looking at both of these, we can start to identify pre-treatment is a time where our caregivers are telling us they're really struggling. Okay. We also took a look at social support. Our caregivers consistently endorse lower levels of social support at all time points as compared to their patients. In addition to that, social support was dwindling over time. So not only do they have comparatively less, it was reducing in terms of intensity and availability across time. So key takeaways here for us. A significant percentage of our caregivers endorse high depressive symptomatology and quality of life reductions alongside dwindling social support. Patients and caregivers often experience different symptom trajectories too, as we saw there on the visual. So we can't make the assumption that they're moving in tandem as a dyad. They might have very differential experiences based on their role demands and other resources available. As I mentioned, pre-intervention is a particularly challenging time for our caregivers. As such, they really warrant and deserve the research and clinical attention. Similar to our patients, we have got to start putting them on the map. It is insufficient to assess strictly the status of our patients alone. In addition to assessing, we need to figure out how to start involving and folding in more clinical interventions. I really want to make sure that we nest them in the macro context here too. In contemporary times, we are thinking about other stressors that are impacting everyone, including our caregivers. And so anecdotally and within the burgeoning literature base, we're seeing our caregivers tell us that they're feeling increased social disconnection, economic distress, health-related anxiety. I can pull lots of terms here from history that are very familiar to many women when we're thinking about the gender impacts of caregiving. Oftentimes are in the caregiving role and the tried and true sense of a double day, so working and then going home to care for someone, or trying to do both simultaneously, or having kids, doing homeschooling and the laundry piling up. All of these things are very applicable to the current context in which we're finding ourselves. This is not my term. I do not take any credit for these, but a lot of people are referring to not a recession, but a she-session too. So differential gender impacts of what we're experiencing right now in contemporary times are certainly infiltrating the experiences of our caregivers. So what do we do with this? In addition to integrating caregiver well-being continuously into the research mission that we have here, we are hoping to build in more conversations, more opportunities for assessment, more clinical attention and materials available to our caregivers, trying to fold this in as standard of care. We have tried this here, and it is understandably challenging, but we're trying to do a better job of prehabilitation efforts, whether or not that's in person or virtual. So thinking about upstream interventions, how can we have more proactive investment to improve postoperative outcomes? How can we think about things like bolstering social support, stress management, informing expectations at the upstream piece as opposed to the downstream, trying to do more reactive interventions? Of course, having emotional support, psychosocial oncology support like we do here. I know within our group, we switched a lot of offerings to virtual modalities, which means that we can reach folks who are geographically distant or who are struggling economically or in other ways, just finding difficult barriers to coming and meeting with us in person. So getting more creative in terms of modality and ways of approaching people. And also, I know we're trying to just think about how to connect with other caregivers in terms of resource allocation. And I listed one open protocol here at Wake that's doing just that. So I'd like to end today with a poem that one of my colleagues shared with me. And I chose this because I think it really highlights the myriad ways that the role demands can stretch our caregivers, both in positive and challenging ways. And this is just a few of the many stanzas within this poem, but I think it really speaks to the shared challenges of caregiving within and across contexts. And I will leave this the screen on for a few minutes just so you can read them. And I think it talks about personal growth and also the challenge and inherent need to build in more routine research and clinical offerings for our caregivers. Thank you very much for your time today.